Well, hello everyone. I hope everyone is having a great evening. If you have went to any Halloween trick or treat, trunk or treat activities, I hope that you found it fun in advance of the real Halloween next week. I'm already tired out, but anyway, really excited to get started today. The health committee is going to be hosting this at-large meeting tonight. So really excited to hand it over to Mercy and the team to talk more about prostate cancer awareness and the work that they've been doing with AdMeTech.
Thank you. That is our branch president, Isis Patterson, with a branch announcement. Thank you very much, Isis. Now we're going to get started with today's meeting. My name is Mercy Njuguna, and I am the chair of the Health Committee. I welcome you all, and thank you so much for joining us. I am grateful for the continued support and partnership with the AdMeTech Foundation, who we're very lucky to have this evening presenting this continuous. We've done this, I believe this is our fourth year of the prostate cancer awareness. Welcome you all, and I'm going to hand the mic to my colleague, Lori Paskovitz.
Good evening. As Mercy said, my name is Lori Paskovitz. Thank you for joining us tonight for this important conversation about prostate cancer awareness and early detection, particularly among Black and Hispanic men who face some of the highest risks and greatest disparities in diagnosis and outcomes. Tonight, we're joined by two remarkable physician leaders who are passionate about improving men's health, advancing equity, and making sure that every man has access to timely screening and the best possible care. Tonight, they'll share insights and practical guidance and stories that highlight how early detection saves lives. We're so grateful you've taken the time to be part of this discussion. Awareness and education are where progress begins. So thank you for being part of the movement towards greater health equity for men. Let's get started.
And we were expecting the North Shore State delegation here tonight. Any of the members here yet? Senator Lovely, Crichton, and Senator Tarr. I do believe there's right now a formal Senate session happening, and I am receiving messages that they might be able to join us at the end of the meeting. Senator Tarr sends his regret if he's not able to make it. Back to you, Laurie.
Okay, so we're going to start out today with Dr. Allison Levy. She's a board-certified urologist who specializes in advanced surgical techniques for prostate cancer. She cares for patients at Beverly Hospital and Leahy Hospital and Medical Center, where she serves as the director of urological robotic surgery. Dr. Levy is known for her expertise in minimally invasive and robotic procedures, which helps patients heal faster and return to their lives sooner. Dr. Levy earned her medical degree from Columbia University. She completed her urological residency at Leahy Hospital and Medical Center, and then she received advanced training in urological cancer surgery at Henry Ford Hospital, which is one of the nation's leading centers in robotic prostate surgery. Her work focuses on advancing prostate surgery, precision medicine, and active surveillance, which she'll be talking more about tonight. She's committed to helping men understand their treatment options and making confident, informed decisions about their care. Please join me in welcoming Dr. Allison Levy.
Thanks so much for having me. I'm really excited to have the opportunity to present this evening. So I'm going to get started talking about some updates in the diagnosis and treatment of prostate cancer. So we'll start basic here. Where is the prostate gland? So the prostate gland sits deep in the pelvis between the bladder and the urethra. Urine coming down from the kidneys is collected in the bladder, and then it flows through the prostate and out the urethra. The prostate's job is otherwise to just produce some of the fluid that comes out in the ejaculate. Who's at risk for getting prostate cancer? So anyone with a prostate is at risk of developing prostate cancer, and about 1 in 8 men will be diagnosed with prostate cancer in their lifetime. The average age of diagnosis is 67, and as you can see in this chart, it's much more likely to be diagnosed with prostate cancer at an older age, but we do see some diagnoses in younger men. There are risk factors that make it more likely that someone could develop prostate cancer, and also that diagnosis could happen earlier in life. So those include being African American, African and Caribbean descent, genetics, which can include family history with other cancers, as well as a personal family history of prostate cancer. But it's really important to remember that most men who are diagnosed with prostate cancer will not die from it. Who should be screened for prostate cancer? So in general, most men can begin screening between the ages of 45 and 50 years old. But men who fall into those categories that I mentioned earlier may want to begin screening earlier, maybe between 40 and 45 years old. It's generally agreed upon that after the age of 70, most men can stop screening. And that's because in general, prostate cancer is a slow-growing disease. So most men who are diagnosed with prostate cancer at a much later age are more likely to die with prostate cancer rather than from it. The first test in screening should be a simple blood test, which is PSA, that's prostate-specific antigen. And many providers will also use the digital rectal exam, which can be incorporated in the screening process, but is not required. So if you're not comfortable with that, you should just tell your provider that you don't want that part of the exam. So what's a normal PSA? Well, this is a really difficult question to answer, and there's no absolute right answer to this. These guidelines are provided by the American Urological Association, which suggest cutoffs over which we should be investigating the PSA more to determine if a patient could have prostate cancer. But these don't apply to everyone. So if a man starts off with a very, very low PSA and we start to see that rise, even if we don't reach these cutoffs, it's possible that man should have additional screening. And on the flip side of that, some men just have larger prostates and have a higher PSA, so they may not require further screening. There are a lot of other tools available, and this gets into more of the newer technologies that can be incorporated in prostate cancer screening. So I'm going to start by talking about MRI, and this is very, very commonly used in the screening process for prostate cancer. MRI can detect about 85% of clinically significant prostate cancers. It does miss about 15%, so it shouldn't be the only tool used, but it's a very, very good test when we're looking at patients initially. After you have an MRI, the radiologist will look at the images and decide if there are any areas that are concerning. They'll assign a score, which is in a range of 1 to 5. And if a score of 3, 4, or 5 is assigned to any part of your prostate, then it's likely a biopsy will be recommended. If you don't like being in enclosed spaces, you should talk to your doctor about that, because there's often things we can do to make the experience manageable. There are also urine and blood tests that can be performed to help guide decision-making during this process. I'm first going to talk about urine tests, and there are many tests available. I'm just listing one of them on the screen here. So some of these tests do require you to be in the office and to have a rectal exam performed prior, but others can be performed at home. This doesn't replace a biopsy, but it can help patients make the decision between foregoing a biopsy or moving forward with a biopsy. Similarly, in addition to PSA, there are other blood tests that can be performed that can help predict whether a patient is likely to have prostate cancer or not. Most of these use a common protein in the blood that's PSA, but free PSA, but many incorporate additional biomarkers to help us understand what a patient's risk is. Similar to urine tests, these don't diagnose prostate cancer, but they can help us decide whether or not to move forward with additional testing. Let's say you and your doctor decide that it's time to have a prostate biopsy. So this is how we actually diagnose prostate cancer. Core needles are inserted into the prostate and actually take tissue out, which is then analyzed by a pathologist. There are many ways of doing this, so these are also important conversations to have. Sometimes these are performed in the office, whereas in other cases, they're performed under sedation. There are two approaches that needle path can take. Either the needles go through the rectum. The alternative is that the needles go through the skin under the scrotum to access the prostate. All of these methods are okay. It's just a matter of what you're comfortable with and understanding the risks and benefits of each. The important thing is if you had an MRI before and the MRI detected an area that's concerning, that MRI should, the biopsy should target that area to make sure that we're doing the best detection of prostate cancer. So let's say you do get the diagnosis of prostate cancer. The first step is to classify your risk group. So you might be low, intermediate, or high risk. Some patients will be recommended to undergo additional imaging. So this could include a CT scan and a bone scan, or sometimes a specialized PET scan that's designed specifically for prostate cancer. And then you need to talk to your doctor about your options. And at every point in the process, the decision-making should be shared between you and your treatment team. Treatment options break into 4 big categories: active surveillance, surgery, radiation-based treatments, and focal therapy. Maybe you're not ready to treat your prostate cancer and you fall into a lower risk category. In that case, active surveillance might be the right choice for you. In many cases, we consider confirmatory testing on the biopsy tissue. So this doesn't require you to go through anything additional, but the biopsy samples are sent off to a special lab, and 2 of these are shown on the screen here. And these can help predict, is your prostate cancer the kind that's more or less likely to progress to something more concerning? If you're in an active surveillance protocol, you'll undergo periodic blood tests, repeat MRIs, and biopsies. Many patients on active surveillance can defer or even avoid treatment altogether. If patients are appropriately selected for active surveillance, they're at very low risk of missing the window for cure. Let's say that you just want to get that prostate out. Then the right thing for you is surgery. So most people are performing robotic, which is minimally invasive keyhole surgery to remove the prostate. In general, patients are in the hospital overnight or even discharged the same day with a catheter that remains in the bladder for between 5 and 7 days. The downsides are temporary urine incontinence, which is leakage of urine requiring pads or diapers, and this can last anywhere between a few days to a few months, and in rare cases is permanent. And the other risk is sexual dysfunction. A special technique called nerve sparing is appropriate for some patients and can improve sexual outcomes. Maybe you don't want surgery, but you do want your prostate cancer treated. Then radiation might be a good, less invasive option for you. There are many ways to deliver radiation to the prostate, which include implanted and temporary radiation devices, as well as external beam radiation. The downsides may be a long time commitment and in some cases can worsen urinary and bowel problems. There's a comparable risk of sexual side effects in the long term, and it's important to remember that surgery and radiation have the same rate of cure. Newer technologies include HIFU, which is ultrasound-based treatment, cryotherapy, which is freezing of the prostate, and laser therapy. These are newer technologies that are not appropriate for all patients, but may be a good option for some. In general, these are considered to be less invasive, and we don't have robust long-term data, but these are evolving, and we're going to learn more and more about these with time. So in summary, you should talk to your doctor about when it's appropriate to start screening for prostate cancer. There are a lot of new options available to help you make decisions along the way. about screening, diagnosis, and treating prostate cancer. But at every point throughout this, you and your doctor should be a team making shared decisions. If you scan this QR code, you'll be taken to my office website, and I'd be happy to answer any questions you might have.
Thank you so much. I think we were going to do questions at the end. So if you have questions for Dr. Levy, just hold on to them. And in the meantime, I'd like to move on to our leader. I'm honored to introduce Dr. Faina Stern, an international leader in the fight against prostate cancer and a passionate advocate for men's health equity. She is the founder, president, and CEO of AdMeTech Foundation, the Boston-based nonprofit she has led for more than 25 years to expedite research, education, and advocacy for advancing early detection and saving lives. Under her leadership, AdMeTech helped drive the first U.S. congressional hearing on prostate cancer diagnosis and made Massachusetts the first state to recognize prostate cancer as a public health priority and major health disparity. Dr. Stern is the daughter of a prostate cancer survivor, and her mission is personal and urgent: to make sure no man dies because his cancer was found too late. She has previously served as faculty member in diagnostic imaging at Mass General, Beth Israel, and Children's Hospitals of the Harvard Medical School. As a senior leader at the National Cancer Institute, the National Institute of Health, and the U.S. Department of Health and Human Services. And she has advised the National Academy of Sciences, the U.S. Congress, the U.S. President's Cancer Panel, Vice President Biden's Cancer Moonshot, and other national and international organizations and initiatives. Please join me in welcoming Dr. Faina Stern.
Thank you so much, Lori. I really would like to express my gratitude to North Shore NAACP and its leadership for fifth year of this event and fifth year of partnership since 2021. Thank you so much. And at this point, I would like to proceed with my presentation. We've had so many problems with PowerPoint presentations in virtual setting that we started creating video. But before I will proceed with my presentation, Santa Lovely, would you like to say a few words? Santa Lovely and other members of the North Shore delegation to the Massachusetts State House are leading the charge and making for supporting prostate cancer program in Massachusetts, and we are very grateful. Santa Lovely, do you want to say a few words?
I am here. Can you all hear me?
Yes, we can.
Okay, wonderful. Thank you. I am driving back to the district. The Senate just got out of formal session about a half an hour ago, but I am safe, so don't worry, I'm hands-free. And Dr. Stern, I did want to log on, and I'm sorry I was a little bit late, but I just wanted to say thank you to the North Shore NAACP for hosting this important discussion tonight, and to you, Dr. Stern and AdMeTech, for all of the work that you have done. You have taught me so much as a legislator, as a wife, and to really understand the dire circumstances of prostate cancer, for men to be screened as early as possible, and actually to get regular screenings so you can really catch this cancer before it becomes pretty dire. And we know that men of color, Black men in particular, are much more susceptible, 2.5 times more likely to get prostate cancer. And so we just know in our colors of community how really important it is to be screened. So I just want to say thank you. Thank you for all that you're doing. Please know that I will continue to be a champion in the State House together with Senator Rush, who in the Senate has also supports AdMeTech and all the work, but for the entire Senate. thanks for the opportunity to say a few remarks. Keep up the great work. Thank you.
Thank you so much, Cynthia. Lovely. Emma, do you mind initiating my video?
My name is Faina Stern. I'm a physician and president of the AdMeTech Foundation, a nonprofit organization leading regional, national, and global programs in prostate cancer education, research, public awareness, advocacy, and clinical care equity. I'd like to thank North Shore NAACP for partnering with AdMeTech in presenting this joint 5th annual prostate cancer awareness event. Also, I'd like to express my gratitude to members of the North Shore delegation to the State House who made our programs, including today's event, possible. In my talk, I will describe AdMeTech Foundation's history and our prostate cancer programs, established to lead cutting-edge advances in patient care and eliminate health disparities. In particular, the focus of my talk is on the AdMeTech Foundation's Prostate Cancer Equity Resource Project, created to ensure that all Massachusetts men have access to high-quality care, including the cutting-edge advances in screening, diagnosis, and treatment described by Dr. Levy. History of AdMeTech Foundation and its programs is closely tied with my own professional and personal history. Since 1990, I was head of Diagnostic Imaging Research Branch at the National Cancer Institute. In this position, I was leading development of national and international research policy and related strategy and programs for the National Institutes of Health, Department of Health and Human Services, and U.S. federal government. Our priority focus was on the advancement of breast cancer imaging. We created digital mammography, breast MRI, advanced ultrasound, and molecular imaging for improved patient care. We also worked on teleradiology for image transmission for a second opinion, so that we could bring world-class expertise to underserved, rural, and remote communities. These breast cancer programs led to transforming screening, early detection, and treatment of breast cancer and reducing health disparities. Precision imaging made it possible to improve screening and accurate diagnosis, critical for early detection and saving lives for all women. To create minimally invasive lumpectomy, when we identify and remove only a part of the breast tissue containing tumor. This minimally invasive lumpectomy replaced radical surgery such as mastectomy, when the entire breast and surrounding tissues are removed. Lumpectomy is performed in outpatient clinics with minimal complications, pain, suffering, and costs. Precision imaging and early detection also made it possible to reduce health disparities in Black women. In 1996, while our breast cancer programs were well underway at NIH, I brought together the key leaders of government, medicine, and industry who recommended prostate cancer as the next national priority focus for several reasons. First, prostate cancer is the most common major internal cancer among men. It is as common among men as breast cancer in women. Prostate cancer strikes 1 in 8 men, while breast cancer strikes 1 in 8 women. And yet, prostate cancer diagnostics and care lagged behind breast cancer by several decades. Second, prostate cancer screening with blood test PSA was successful in identifying men at risk of losing their lives and in reducing mortality or death from prostate cancer. However, men needed accurate diagnostic tools that would make it possible to sort out if abnormal screening result was due to false alarm or due to a life-threatening prostate cancer. Accurate diagnostic tools would make it possible to create personalized and most effective plan for clinical care for each man and avoid unnecessary procedures. Third, treatment of prostate cancer, such as radical surgery, was highly invasive and traumatic, leading to prolonged hospitalization, difficult recovery, and the unacceptable level of life-altering complications. Similarly to women with breast cancer, accurate imaging would make it possible to develop minimally invasive treatment for men with prostate cancer or male lumpectomy. Fourth, prostate cancer is a leading health disparity. Black men are 2.5 times more likely to die compared to white men. We did not see this level of disparities in breast cancer even early in my career, in the 80s and 90s. Finally, in sharp contrast to women with breast cancer, men did not have accurate imaging, leading to blind biopsies and treatment. Our work in breast cancer imaging created a blueprint for transforming prostate cancer care. At about the same time in 1996, I had a personal experience that left me rather shocked. A leading clinical expert in Massachusetts, chosen by me, examined my father and determined that he had a benign and common prostate condition. However, when my dad had an invasive procedure, he was found to have prostate cancer. It was stunning to me that the leading expert in a world-leading hospital did not have the appropriate tools to make accurate clinical diagnosis. This experience transformed my professional interest in prostate cancer into a personal mission to improve early detection and treatment of prostate cancer for all men and to reduce health disparities in Black men. If we made a difference for women with breast cancer, we could make a difference for men with prostate cancer. I mobilized other leaders of medicine, and we approached National Cancer Institute and NIH in the hope to see an increased government investment in prostate cancer research. Unfortunately, in spite of our joint track records and a year-long effort, we did not succeed in convincing US government. In response to the lack of support from federal government, by late 1997, we established AdMeTech Foundation with the mission to end blind patient care and create the future of image-guided, minimally invasive diagnosis and treatment. We call it the Manogram project. Since 1997, AdMeTech has been leading a pioneering research that resulted in creating precision MRI, molecular imaging, and other imaging tools that transformed prostate cancer care. In 2005, we initiated a large-scale national public awareness campaign, Where is Manogram? Prostate Imaging for Men. In 2009, we had the first annual Prostate Cancer Awareness Day in Massachusetts State House and proceeded to create a new model in public education. In 2011, as the result of our advocacy, Massachusetts legislature had set up a historic precedent by recognizing prostate cancer as the central health care problem in men, a leading health disparity and public health priority. By 2013, Massachusetts legislature established a prostate cancer program. It started as a research project that was seminal in making MRI a new standard in patient care for guiding biopsies and treatment. Since 2014, we expanded our efforts in public awareness. In 2016, we established annual global summit on precision diagnosis and treatment of prostate cancer, a medical educational event. In 2021, we had launched Prostate Cancer Equity Resource Project, I'll describe later. In 2023, we created an international working group in minimally invasive treatment to expedite clinical implementation of this new approach to clinical intervention. Our statewide program in prostate cancer created a Massachusetts model of national and global leadership in public awareness, medical education, research, and health equity. AdMeTech is leading prostate cancer program in cooperation with multiple organizations, including American Cancer Society, leading state clinical experts, and multiple branches of the NAACP and Latino health insurance program located across the state. Our primary focus is on high-risk men, Black, Hispanic, and Latino individuals, and all men with family history of prostate cancer and increasing age, 50 and older. Our public awareness has focused on the importance of screening and early detection, critical for saving lives. Since 2019, we reached well over 71,000 people. The centerpiece of AdMeTech's medical education is annual global summit on precision diagnosis and treatment of prostate cancer. Our summit has been recognized as a seminal event in shaping the state-of-the-art and future vision for patient care. Our summit brings together the key international experts representing every clinical field to review the best emerging clinical practices and research needs and priorities. There is not a corner of the world that has not been represented at this event. The latest 9th annual conference took place only in September 2025, several weeks ago. Our summit demonstrated that early detection saves lives and eliminates health disparities. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast, with late diagnosis, when cancer is spread outside of the prostate to other organs, only 28% of men remain alive at the same time. Early detection is particularly important for high-risk individuals, including any man with family history of prostate cancer or Black men who are twice as likely to die as white men. In prostate cancer, screening with blood test called PSA is the best tool we have for prevention and early detection, critical for saving lives and reducing health disparities. If we look at the reduction of mortality per year, PSA blood test is the most successful screening tool we have had in the history of cancer. It is important for men to take charge of prostate health. To do that, it's important to know your risk factors, such as Black heritage, family history of prostate cancer, particularly when your brother or father had this disease, and increasing age, 50 and older. You can assure early detection during annual visit. Ask your doctor to discuss if PSA blood test and digital rectal exam are right for you. You need to talk to your doctor starting at the age of 40 if you have risk factors I just described, or at the age of 45 if you do not have these risk factors. Before screening, it is important to avoid exercise or sex, which may impact your testing results for at least 2 days. After screening, you need to ask your doctor if your test is normal or if you need to see a prostate cancer expert for further evaluation. Our summit concluded that equal access to high-quality care is the key factor in improving patient outcomes for all men and eliminating health disparities in Black men. It is particularly important now with so many novel diagnostic and therapeutic approaches, ensuring high quality, personalized patient care. Without equal access to these advances in patient care, we will see a widening gap in health inequalities, including survival and mortality. Consequently, AdMeTech launched the Prostate Cancer Equity Resource Project in Massachusetts in collaboration with Mass General Brigham, UMass, and other clinical institutions with the mission to save lives and deliver high-quality care for all. More recently, experts from Beth Israel Lahey joined us. Supporting organizations include Latino Health Insurance Program and multiple NAACP branches located across the state. Any Massachusetts man age 40 and older is welcome to participate. Our priority focus is on Black, Hispanic, and Latino men who are at high risk of prostate cancer, delayed diagnosis, poor quality care, and death. Our goal is to expedite access to leading experts who use the most advanced approaches to screening, diagnosis, and treatment available today, and to support men every step of their medical journey. This program helps men to find an expert for the initial or a second opinion in person or virtual visits. We believe that in Massachusetts, with its leading hospitals and universal access to care, our prostate cancer equity program will be able to eliminate health disparities. Experts of the prostate cancer equity program can address any questions about prostate health, from assessing an individual healthy man's personal risk of cancer longer term, to informing men about all available options before and after screening, biopsies, and treatment. We are committed to supporting men during every step of their medical journey to ensure that no man is left behind or struggling alone. To achieve this goal, we created a streamlined process of patient referral and care, reflecting how doctors involved in this program would like to take care of our families and friends. This process consists of several components. First, AdMeTech Foundation's team collects basic information and match individual patients' needs with the appropriate state's experts for clinical care. Second, a clinical organization designates a patient navigator to expedite a medical visit and related needs, including scheduling, registration, transportation, financial, and insurance assistance if needed. Third, if an expert recommends any next steps, AdMeTech's team and patient navigator work with men on the appropriate follow-up, such as, for example, additional testing or treatment. I'd like to provide a few recent examples of how PCE Resource Project has been making a difference. In December 2024, Martha's Vineyard NAACP asked us to help an older Black man who expressed a lot of confusion and concerns about his care. AdMeTech staff contacted Dr. David Einstein at Beth Israel Lahey, who agreed to provide a second opinion. In February 2025, this man and his wife had a visit with Dr. Einstein, who provided a clinical consultation and contacted the original clinical care team to ensure a coordinated approach. In March 2025, this man and his wife described that as a direct result of Dr. Einstein's consultation, they understood their situation for the first time and became clear about the next steps. The second example involves George Brickhouse, who in December 2022 took part in the virtual meeting of the PCE resource organized by Steve Bernard, immediate past president of Brockton NAACP. During that meeting, George expressed the lack of trust in his care and difficulties in scheduling prostate MRI recommended by his doctor. We got concerned And after the meeting, contacted Steve and asked him to explore with George if he would be interested in our PCE resource. In early 2023, George contacted us and we suggested for him to consult with Dr. Kwok Trink of Mass General Brigham, who can ensure the best of last care, including high quality MRI. George has been so happy with his care that he became an advocate for our prostate cancer equity resource. In late 2024, Dr. Trink moved to Pennsylvania due to academic promotion. In March 2025, per George's request, we referred him to Dr. Adam Feldman, another leading clinical expert at Mass General Brigham and our partner at that clinical institution. Emma Coyer serves as a manager of the Prostate Cancer Equity Program. Emma is assisted by Erin Roberts, program coordinator, Craig McClay, patient educator, and other members of the AdMeTech Foundation's team. We serve as your individual patient care advocates. When you come to us, Emma will work with you, our team, Mass General Brigham, UMass, Beth Israel, and other clinical partners to expedite medical visits and address any needs you may have. Together with clinical experts, we empower each man to make informed choices in patient care that are right for him before and after screening, biopsy, and treatment. If you have any questions or need assistance, please contact Emma by phone 617-523-3535 or by email coordinator@admetechfoundation.org. Thank you for your attention. While Michael is typing his questions, anyone else has any questions for Dr. Levy or me?
Go ahead, NAACP North Shore.
That is me, Mercy. Thank you so much, Dr. Levy and Dr. Stern. Dr. Stern, definitely this has been a personal journey for you. Thank you so much. My question is on the PCE project. So we're in the North Shore. Let's say I go to the closest hospital, Beverly Hospital. Do they know about you, or how do they get me in touch with you? Let's say I wasn't in this meeting.
That's a great question. We have a lot of events like we are having today to let people know about our resource, prostate cancer equity resource, to let as many Massachusetts men know about this resource. And yet, I honestly do not know about specific individuals or specific hospitals or specific locations. We are trying to do as broad campaign as we can. By the way, I was remiss. Emma, do you want to share a testimonial from President Reeves, president of Cambridge NAACP, his experience with our program?
My name is Kenneth Reeves. I am the president of the Cambridge branch of the NAACP, as well as the former mayor of the city of Cambridge, Massachusetts. My intention is to say a word about the AdMeTech Foundation and its offerings and benefits, particularly to communities of color and particularly to Black men facing issues with respect to prostate cancer. I would say that in Cambridge, we've been in the men of color health business for more than 25 years. And so we have a men of color health outreach. However, I think we've become much more knowledgeable about ways in which we can assist the men of our city. And we particularly have become much more knowledgeable about prostate cancer and its impact on particularly Black men, who are 5 times as likely to be affected by prostate cancer than white men. So that being the case, and I've dealt with prostate cancer theoretically, and then 4 years ago, I was diagnosed with prostate cancer. So I have my own journey. And after diagnosis, I was able to hear what my treatment options were. And I chose something called CyberKnife, which is a 6-day treatment where you go every day for about an hour. There is a a laser approach to the cancer. And after that, I was able to be clear for almost 2 years. And then suddenly my PSA, or prostate specific antigen number, kept going up, and no one could figure out why. And I had many MRIs and other tests. And that's when I met AdMeTech, because I was describing this to a friend, and they said, "You sounds like you're lost in the maze of, what to do when your numbers are inexplicable." So I was in touch with our Dr. Stern, and basically I had to tell her there is a test that they don't have in Boston that I need to have. It's an imaging test. It's very advanced. It's in Europe, but not yet approved by the FDA. And she said, "I'll get it for you." And she was able to arrange it through Sloan Kettering in New York. So after much red tape and bureaucracy, I was able to get that imaging test, and it did find where the prostate cancer had moved to an area around my lung, which my doctor, who's a very important, famous department head at Dana-Farber, said he had only seen one case in his career, so he was pretty sure it wasn't to the lung. So I then learned that, the physicians are great, but they're not God. So I called him and said, "Guess what? I'm number 2. And after being number 2, I still have had to have these various questions that I don't feel competent to answer about what next steps should be in my medical care. So while I have a wonderful team at Dana-Farber, who Dr. Stern led me to, but even in all that wonderfulness, there are questions that I don't feel competent to answer. So she just 2 days ago helped me to answer 2 great big questions. So I think this is timely for you to hear that. In my big questions were whether I should participate in a particular study, which would, I'm now on a very expensive pill that has my PSA number at 00000. So this is $16,000 a month. And the question asked of me by my doctor is whether I would participate in a trial which would essentially stop this pill, let the cancer come back, and then observe what that does with respect to the testosterone level. And the doctor also said, "Well, we don't get many Black men in trials, so we'd like to get it would be important if you were to say yes." And so this was hanging over my head like a cloud. I couldn't decide, because I want to do whatever I can do that will be helpful to both science and to prostate cancer with respect to Black men, because self-interest is a wonderful motivator. Her immediate reaction was, "Not for you, because you had one of only 2 cases with your particular doctor. The experience with people like you for such a trial is too small. And so you should be very thankful to the doctor, but it's not for you." Thank God for having a foundation that's devoted to navigating men of color through the maze of prostate cancer, to be able, with a scientific point of view, give that kind of direction and consultation. So I must say that is great.
Grateful to President Reeves for this testimony. And we have a question from Michael in the chat. And his question is the project a Massachusetts model or the project nationwide project? But by the same time, we are very mindful of creating a Massachusetts model that works and that can be utilized anywhere else in the nation or even internationally. The second question Michael has is, CDC has statistics for 2007 with mass not in a great place. Has Massachusetts stats gotten better since the program started? Yes, but in a relative, at about 10%, it's a relatively modest statewide impact. And yet, if we look at our focus of efforts from our priority that we chose, and that was Plymouth County, who had the highest Black man mortality in prostate cancer in 2015. We actually shared this with Brockton NAACP, and we created partnership. Brockton NAACP initiated a very broad community outreach from mayors to other elected officials to local TV, local papers, etc., etc. Within 5 years, we saw 55% drop in mortality in Black men and 30% drop in mortality in white men. If we look at the disparities, which we measure as a ratio of mortality in Black men to mortality in white men, we started when Black men in Plymouth County were dying roughly at a rate of 2.7 times higher, which was higher than Massachusetts average. It was higher than national average in 2015. By now, it is, by 2021, it had dropped to about 1.25, almost a level of parity. So what we did in the process, we built a model within Massachusetts, Michael, that works. Broad community engagement, cutting-edge care made available to men, cutting-edge information made available to men. We created this model, broad outreach, and that now is serving as a model for our activities in Worcester that currently leads Black and Hispanic prostate cancer mortality, and in Hampden County that is second, that has the second highest mortality. So that's where we are. I also have to say that it takes a while, it takes years to see differences in statistics such as mortality. I think we have another question, and this is from for Dr. Levy. Dr. Levy, do you mind addressing question in the chat for you?
Of course. So Lori's question was, I mentioned active surveillance as an option for some men and 4 different choices. And the question is, are all the treatments available for most cases? Can a patient truly make the decision? So the answer really is no. It's really important to look at the details of each individual. Every prostate cancer behaves differently. So a lot of men fall into this low risk category, and those men can have their pick of any treatment. And the intermediate risk is when things get a lot more complicated. And that's when I start using these other tools towards what is going to be their best long-term outcome. And then in the high risk end of the spectrum, we have fewer options available because we're much more concerned about metastatic disease, the kind that can really impact longevity and quality of life. So the details are really important.
Any other questions, Dr. Levy or me?
I have a whole bunch of questions. This is such a fascinating topic. This could be for both of you, but looking ahead in prostate cancer treatments, what gives you the most hope? What are the new opportunities coming that, that might, besides this awesome navigation program, what other clinical modalities are happening that we can look forward to, or maybe have more things that we need to then make sure all patients have access to? But maybe could you answer that question?
Levy, would you like to address this question?
Sure, I can get started. So I think that it sounds like the mission of AdMeTech is really the number one key, which is early detection, early diagnosis, so that you really have a wide range of options available to all patients. I look forward to having tests that are better than PSA because as I mentioned earlier, PSA is just such a small part of the picture. I have patients with what would, objectively be low PSAs who we end up detecting aggressive prostate cancers. And on the other side, men who, Dr. Stern, like your father, have enlarged prostates, high PSAs. We treat their enlarged prostates and they do great. So I'm really looking forward to the next non-invasive test that outdoes the others. Currently, all of these blood tests are sort of about the same. They add a little bit of information, but they haven't convinced me that every patient should get them, but I know it's coming. I'm sure the research will get us there.
So much. And actually, at our summit, what has become very apparent over the last 10 years, and that's why we actually established the summit. So we will look beyond a specific test or blood test or urinary test or imaging, and actually look at the possibility of their integration, taking down the silos. And what we started seeing is incredibly exciting body of evidence demonstrating that the future of early detection of prostate cancer is actually integration with PSA, which is a pretty great screening tool, but inadequate diagnostic tool. Blood tests, urinary tests, with genetic tests, with imaging. And it is this integration of precision diagnostic tools that are complementary in nature that make it possible for us, based on this data, to accurately identify individual men who are at very high risk of having or getting life-threatening prostate cancer vis-a-vis men who are at very low risk of prostate cancer. And thank God, the majority of men are low-risk men, so we can reassure them in a precise way, and we can identify a small fraction of high-risk men. If I look at the spectrum of treatment, Lori, I would say that from my perspective, just like I saw evolution from radical mastectomy in breast cancer with precision imaging and other precision diagnostics to lumpectomy. We started when, radical mastectomy deformed women's bodies. It created incredible suffering and consequences. And I believe the future of treatment for many men is minimally invasive treatment. We already had a very important step that Dr. Levy described, and that is a transition from open surgery, when men's body were open, to robotic surgery, which is a keyhole surgery, as Dr. Levy pointed out. The recovery period is unrecognizable. I believe that for many men, the future will be male lumpectomy, when through imaging and other diagnostic tools, we will identify precisely where cancer is very early, and we'll be able to remove only a part of the prostate that contains cancer. And these procedures do not even require knife at all. They can be performed in outpatient clinics under imaging guidance by administering destructive energy that does not require even keyhole opening. It is also a fraction of cost. It decreased complications on average, based on large trials, 10 times compared to radical prostatectomy, even robotic surgery. So I believe it's a fraction of cost. It does not require hospitalization, that does not require surgical theater, focusing on cancer as opposed to radical prostatectomy. And this will be essentially the impact of male lumpectomy on prostate cancer care, just like we saw the impact of female breast lumpectomy in breast cancer care. Any other questions?
Okay. Dr. Stern and Dr. Levy, boy, you're just doing incredible work, and it's really, really valuable and much appreciated. I guess I was wondering if more advanced treatments are available here locally. The robotic surgeries and the advanced diagnostics and all that.
Yes or no? It's it really it actually our summit. One of the leading speakers at our summit is Dr. Matthew Cooperberg from University of California, San Francisco. And one of his particular interests is to look at patterns of care. And what is very interesting, Carney, is if we look at let's say, tissue genetic diagnostics, which are very important to sort out men who, for example, will be more suitable for minimally male lumpectomy, right? We will see that most of this genetic testing is sort of concentrated in Midwest, in West Coast, and Florida. For some reason, they did not find as much clinical implementation. And I think very tightly related to that, we do not see as much utilization of minimally invasive lumpectomy for men the way we see it in the areas I just described, Midwest, West Coast, and Florida. But we are getting there. But because of our summit, because of our research activities, we can help men get access to this, even if it is not available in Massachusetts, just like President Reeves described. We were behind development of molecular imaging PSMA PET, specialized PET for prostate cancer, mentioned by Dr. Levy, since 2001. And we had access to this technology before it became available in Massachusetts in 2021. And we did something very similar for men who needed MRI but did not have access to the kind of MRI that, for example, National Institute of Health had 10 years ago. So we actually, men came to us and we helped them get connected with focal treatment at the male lumpectomy at the National Cancer Institute and other institutions across the country.
I think I'll just add to that some of the specific things you mentioned. Certainly, robotic surgery is available pretty much anywhere that prostate cancer surgery is being performed throughout Massachusetts. And I think that such a big part of this is determining what like I said before, the individual patient. So if a patient comes and has, as you described, the lump, and the lump is identified on imaging, by all means, there is focal therapy available in Massachusetts. And I'm a surgeon. I love operating. I refer my patients if that's a good option for them. So often, by the time a patient is diagnosed, we're not seeing a lump. We're seeing prostate cancer throughout the prostate. And these options, when you're treating with focal therapy, but you're treating so much of the prostate, the risks really increase even beyond where they would be surgically. So that's why it's just so important to think about the individual case, what's best for that patient, and offering them all the options, even if it's not what you do.
The best diagnostics available so that each individual man will get the kind of treatment that is best for him. Would it be just deferred treatment like active surveillance described by Dr. Levy, or radical surgery, or perhaps focal therapy? Focal therapy in Massachusetts is a relatively new phenomenon, but it is not as popular here as it is in Midwest and Florida and West Coast, but it is definitely available.
Thank you.
Any other questions?
I just want to make a comment. First of all, thank you, both of you, for the work that you do. And to AdMeTech, there's so many healthcare disparities and so many different medical diagnoses. But at least for this one, because of your stunning results, you have really proven with your navigation, connecting people with resources, that it really and truly is about access.
No question. And actually, AdMeTech is particularly closely aligned with National Comprehensive Cancer Network organization that has 28 plus leading cancer hospitals in this country. And the latest conclusion, based on all the scientific evidence we've had, including very extensive clinical trials in tens of thousands of men in the VA system, that access to quality of care determines outcome. That race, when you look at very convincing data from VA system, for example, where people have equal access to quality of care, they eliminated disparities in prostate cancer between white and black men because it's equal access. And this does not depend, men's outcomes in prostate cancer and VA system does not depend on level of education or level of income. It is, it just really strong evidence that the dominating factor is access to care, particularly high quality care.
Thank you so much.
Thank you for your question.
I have a question. Yes, I have a question.
Yep.
My dad was diagnosed with prostate cancer, but when he was younger, he had shaving of the prostate, and I just wondered, did that put it at risk for developing cancer later on?
There is, Dr. Levy, do you want to address this question?
Sure. So I think by shaving of the prostate, you're probably referring to the TURP procedure, which is sometimes described as the Roto-Rooter procedure, where prostate tissue is removed from the inside. And the short answer is no, this didn't change whether or not he was going to develop prostate cancer in the future. So, I have patients who incidentally detect prostate cancer when we're doing the shaving, and all the options are still available, and it doesn't change the patient's prognosis.
Okay.
There is no convincing scientific evidence whatsoever that would form foundation for a concern that biopsy procedures like for benign prostatic hypertrophy that your father probably had, that it increases any kind of risk of cancer, or even if cancer is still there, there is no evidence to show that it increases probability of spread of cancer.
Along that line, a lot of patients ask me, does my biopsy increase my risk of spreading the cancer? And that's another one where we don't have any data to support that it can increase the risk of spread.
There are individual investigators that express concerns based on some commonsensical sort of considerations, but there is no evidence to support it at the moment. Any other questions?
I have another question. So I'm a breast cancer survivor, and when I was 40 years old, I started doing mammograms, and there was a center for it, and it was I think most women, have experienced this breast service, if you have breast cancer, you have the navigator, it's a part of the health system. Also, the primary care office would always do a breast exam. This is directly to the work that you've done. But looking forward, currently, do you know of any hospital systems or programs where the primary care has this standard screening that they're handling? Or do you know of any centers where there is a similar corollary within the system that is a prostate cancer? You just send the primary care patient to the prostate cancer screening center, and then also are there other navigators besides you in the systems?
I would not know about a specific clinical institution that would have dedicated navigators. Before we initiated our partnership with any of the involved clinical institutions at UMass or Magellan Brigham originally, now Leahy, condition for our referral of patients to you is clinical navigator, because as you can imagine, if we have particularly underprivileged men who do not have trust in medical establishment to begin with, and they come to medical system, and one person is telling them, "Oh, you need to see this person in registration." Then registration person is telling, "Oh, you need to talk to scheduler." Then scheduler say, "Oh, you need to talk to financial assistance people," etc., etc., etc. For transportation, for insurance, whatnot. It's just not workable. And if we look at the statistics in Massachusetts, we see that Black men are 22% less likely to follow on physicians' recommendations compared to white men for life-saving treatment, forget about biopsy. And this is, we believe it's a fundamental problem in healthcare system. It's difficult for anyone, but when you are dealing with men in general, particularly Black men, you're going to lose them. Because in addition to bouncing people from one department to another, it is, you're dealing with several people who provide essentially very non-personal, very fairly distant kind of care. You do not establish trust and relationship with people who take care of you. So it was very important for us to actually try this system when we make ourselves available to men who have any questions, and we work with clinical navigators who do the same. So I would not know what clinical institutions have clinical navigators, what clinical institutions we do not. We established our program to make sure we have that. Now, I also want to, you asked about primary care. I think the role of primary care physician is absolutely critical in terms of referral for screening. But, right now, and they can determine whether or not they're also critical in determining if men need further evaluation. But because of a very rapid evolution of diagnostic and therapeutic tools in prostate cancer, the sooner, if physicians have any concern about screening results, the sooner they will refer men, urologic experts like Dr. Levy, the better it will be for men.
Lori, I think your vision is a beautiful one, though. A center where men get their prostate cancer screening, their MRIs, their diagnostics, and where the multidisciplinary clinic is when they get the diagnosis. So hopefully that's something we can look forward to at some point.
Well, it sounds like AdMeTech's getting the data together for how that would be a good value. Yeah. If there's no other questions from the panel, I do have a special video that I'd like to share from a friend of ours, Dr. Guy Fish, who is the CEO of Codman Square Health Center and a national leader in health equity. Dr. Fish is, I already said that. He's the CEO of Codman Square Health Center, where he is focused on supporting underserved communities and connecting everyone with culturally congruent care. He is the immediate past CEO of the Greater Lawrence Community Health Center. He is one of the country's first MD MBAs, and he's been passionately advocating and driving healthcare reform and health equity throughout his entire career. Dr. Fish's multi-industry career also spans international for-profit and nonprofit sectors. He served on the board of the Boston Medical Center, the Mass Health Policy Forum, and other organizations. On October 14th, 2025, Boston Mayor Wu and Boston Public Health Commissioner appointed Dr. Fish as a member of the Boston Board of Health, helping to accomplish their goals for Boston.
Hi, this is Dr. Guy Fish. I'm pleased to be speaking with you today at the AdMeTech conference with respect to prostate cancer, a topic which is near and dear to my heart. A few simple messages to communicate to you this morning. The first is that prostate cancer is something we should all take seriously. But if you have a father, husband, son, uncle, then you also need to take prostate cancer seriously. Why? Because let's face it, men have a hard time taking their own health seriously, and we need a little help. So ladies, please get in the game with us. Number two, what is prostate cancer and why should we talk about it? Well, prostate cancer is among the leading causes of death for men in these United States. And it particularly is hard on Black and brown communities. The number one cause of death for men, well, it depends on how old you are. For Black and brown men under the age of 50, gun violence is certainly top of the list. But beyond that, we have the usual mortalities around cardiovascular death and cancer, and leading among cancer is prostate cancer in men. So let's take it seriously, because every time that a man dies prematurely of prostate cancer, that's a father, son, uncle who's not around to be at our birthday parties, at our celebration events. So let's make sure that generational wisdom and wealth and knowledge is passed down to our generations because they're around, not dying prematurely. So what is a prostate and what does it mean to have prostate cancer? The prostate is a gland that is involved in the men's urological system. It's about the size of a walnut. It sits underneath the bladder, and it provides lubrication for sperm as they usher forth to produce children. Now, that gland is going to be there from the time that a man is born to the time that he dies. And along the way, it, like most organs in the body, those cells know what they're supposed to do. They're supposed to produce the fluids that I mentioned. They're supposed to reproduce themselves in an orderly way and die off in an orderly way, just as liver cells and kidney cells and heart cells do all the time. But in the prostate gland, there's a possibility of cancer developing. And cancer means that the cells have forgotten who they are. They've forgotten certain rules about not continuing on forever, acting like they're immortal. And when that happens, they grow and grow and grow, and then they make a tumor, which can then seed other parts of the body out and into places where it shouldn't be, such as the liver or the lung or the brain. So what we want to do when we are able to is to use the tools and technologies that God has made available to us through human intelligence to detect prostate cancer early. Early detection and prevention are the keys to getting to better outcomes with respect to any cancer, but particularly for men in prostate cancer. So the good news is that it is actually fairly easy to detect prostate cancer early on. What is that and how do you do that? Well, first thing you need to do is, again, recognize that you should be checking up on your health with your doctor. So men, let's schedule those doctor's appointments. We know we don't do that, but we really need to get a scheduled doctor's appointment. And in that doctor's appointment, ask them to please check our prostate. Why? Because African American and brown men have a higher rate of death from prostate cancer. It's not that our biology is different. It's that largely we don't let it become detected until it's too late to do something about it. Most men who have a prostate that is developing a tumor will probably die of other things many, many years later. But some may require surgery because it's moving aggressively or is at risk of spreading. And in that case, there are prostate surgeries which are done mostly robotically these days and minimally invasive. So you don't have to have a big scar like in the past. So what I'm describing is a journey which should engage you in terms of your desire to be here for your children, your grandchildren, your wife and family. It isn't scary. It's just a necessary type of screening that you need to do to be mindful of how you are doing, how your body is doing. You need to take ownership of that. The most important thing of everything that I'm saying is that you need to own this. You need to be an advocate for your own well-being. If your PSA and your prostate exam are going up, you may want to have more specialized testing done. There are new tests that are on the market which are helpful in determining which of these tumors are actually aggressive and which ones are pretty indolent, and you can let them sort of not be bothered with for a while until it changes its characteristic. And you really have to be an advocate for your own health. And that's the most important differentiator between the outcomes in Black and brown communities and the majority of population. How aggressive are we being, making those appointments, speaking to the doctors about what we want, following up on those test results? That's up to you. And it's really up to you to ensure that you're here for your loved ones. So my personal history, my father died of prostate cancer. It was detected a little bit too late for much to be done. He was someone who, like most men, didn't really get his physical exams in on a regular basis and went on to pay the consequences. So I don't want that for you. I just had my annual exam last week. My PSA is in a normal range, thank God. And I will check it again next year. So I hope that when next time we meet, you can tell me that you've done the same. Thank you so much.
I am grateful to Dr. Fish for providing this video and for making this statement. I think it's a great call to action. I hope we shared information that was useful. And if anyone on this online meeting, if anyone in your families, if anyone among your friends, if they need help, please be assured that we stand by ready to help any man through our Prostate Cancer Equity Resource Project. And the first person to contact, as I mentioned in AdMeTech, is Emma Coyard. Back to you, Lori and Mercy.
Well, we've had an amazing night. I learned so much. And, you know, with personal cancer, it's going to touch all of us, I think, at some point in our life, a friend or ourselves. And I just really appreciate the outreach project that you have and Dr. Levy's expertise. It's just been a fantastic night. I thank you so much.
Thank you so much for the opportunity. I hope everyone will have a great evening. I also want to thank Emma Coyard and Thomas Satum, who are managing this event technically and are here tonight with us from AdMeTech.
Thank you so much for having me.
Thank you so much, everyone, for your time, and to Dr. Levy, Dr. Stern, and your team, and Laurie. And we'll see you next month. The branch meeting is every fourth Thursday of the month. And have a happy fall season.